Great.
Perfect. So I hope you all feel a little bit refreshed with that tea and coffee. Our next speaker is Dr. Emma Drasar, who's going to be talking about sepsis and thalassaemia.
Okay. Hi everyone, in the room and also online. So today we're going to cover a brief overview of the thalassaemia syndromes, talk a bit about what is sepsis, because it's something that we hear a lot about on Trust intranet, in the news, you know, sepsis. But actually it might not be what we think it is. Go over some thalassaemia specific risk factors, and then traffic being equal, then Prof Porter will hopefully be presenting some cases illustrating specific issues. Otherwise it will be Dr. E. Drasar presenting Prof's cases. So what are the thalassaemia syndromes? So unlike sickle cell, which is a qualitative problem, so there's plenty of beta and alpha globin chains, but because of the change in the gene that causes hemoglobin S, it becomes a qualitative problem. In the thalassaemia syndromes, it's a quantitative problem. So the change in the gene results in reduced production of either the alpha globin chains in the situation of alpha thalassaemia or beta globin chains in the situation of beta thalassaemia. And basically that means if you haven't got enough of one chain, you end up with too many of the other. So in thalassaemia major, transfusion-dependent thalassaemia, you get premature breakdown, hemolysis of the red blood cells, both in the peripheral circulation, but also destruction of the red cell precursors in the bone marrow and outside of the bone marrow in the extramedullary sites, which is what we call ineffective erythropoiesis. So with transfusion chelation therapy, things have improved. Thalassaemia patients now have an improved life expectancy, although my oldest transfusion-dependent patient is 65, so we do not know what is going to, the future is going to hold for this particular group. And also we know that unfortunately our patients do have a significant morbidity and mortality which can occur at any stage in their lifespan. We know some of the problems associated with thalassaemia. A large amount of those are due to the impacts of secondary iron overload. And in the non-transfusion patients, iron overload can also exist, but also there's the endothelial damage that occurs as part of the chronic hemolysis picture. So, on to sepsis. What is sepsis? So, according to the WHO, who obviously we all listen to in these circumstances, sepsis is a life-threatening condition that arises when the body's response to infection causes injury to its own tissues and organs. So we know, obviously, that we're pretty evolved and we've survived this long to be able to fight off some infections, despite not perhaps having antibiotics until the last 150 years or so. We know that sepsis is associated with significant mortality, and that is dependent on the degree of organ dysfunction. And there's this specific situation called septic shock, which is where you get underlying metabolic and circulatory compromise, and that's despite decent amount of fluid resuscitation. And there's this sepsis 6 that's been well publicised, certainly in most of the inpatient settings, which is what to do if you think someone has sepsis. Does anyone know what the sepsis 6 is? Yeah, good. Basically, yeah, it's all common sense things, but I think it's I don't know, in my experience, it's, sometimes one of the challenges is actually deciding what is sepsis or what is a submassive PE, for example. And so it's important to do all the things that we are, trained to do, which is take a proper history, do a proper examination, listen to the patients, and because very often they will be able to give you good pointers. So there's this sequential organ failure assessment score, the SOFA score, which helps you to sort of differentiate how severe the sepsis is. So it looks at things like the FiO2, the platelet level, is the patient on vasopressors, which, is never a good sign. What's their Glasgow Coma Scale, their GCS? Have they got a raised bilirubin? And are they weeing, or do they have signs of renal impairment? Now, one of the challenges in red cell patients is, and this is for thalassaemia and sickle cell disorder, is that quite often they can either have high or low platelets at baseline, typically higher platelets if they've been splenectomized or if they have had splenic infarcts, or sometimes, certainly my SC patients tend to have lower platelet counts because of splenomegaly, and that acting as a pool to take the platelets out of the circulation. Also, patients with both thalassaemia, transfusion and non-transfusion dependent, and obviously sickle cell disorder can have raised bilirubins at baseline. So it's important to use these scores in the context of from a person-specific level, because in some situations these scores can be used to say what someone's likelihood of a good or bad outcome is, and that may mean that they then get diverted to ward-based care rather than being given a chance to recover from their septic episode on the intensive care unit. So I think it's important that we, draw attention to our ITU colleagues that our red cell patients aren't standard patients in this area, certainly with regard to their bloods. Lactate, well, everyone's obsessed with lactate on a venous blood gas. Interestingly, lactate seems to have no bearing on the SOFA score at all, but we do love it, and certainly ITU colleagues do as well. So what's the challenges? Interestingly, you'll note that I haven't mentioned fever at all yet. What we know is that you can have significant sepsis without fever, so-called cold sepsis. However, obviously, if someone's spiking 38, 39, then that's a clear pointer that there's an infection going on. Neutrophilia has many causes. We know, again, it's important to look at the patient in their context. Do they have a baseline neutrophilia because of their underlying health condition? And you also need to be aware about overdiagnosis, because overdiagnosis can lead to overaggressive fluid resuscitation, which can, particularly in our red cell patient cohort, lead to fluid overload and subsequent cardiorespiratory compromise as the result of that. So certainly in sickle cell disorders, we've moved away from the hyperhydration IV, and we need to take care in our thalassaemia patients, particularly those who have had previous cardiac iron and cardiac compromise as the result of this. So coming back to our thalassaemia patients, they do have specific clinical factors that they can increase their risk of sepsis. So I'll go on and talk about those now. So thalassaemia patients, as Sakai was talking about earlier, are more likely to have indwelling ports or lines, which can provide a potential source of infection. Porter cats have a lower risk of this than long lines, such as PICC lines, but they are harder to remove if a patient does develop an infection. And that involves, a lot of calls to the surgical registrar. Most of that data, by the way, on line infections is taken from the malignant, the cancer setting, and that's basically based on patient numbers. So it's difficult to comment whether that is the same situation in our red cell patients who obviously aren't undergoing chemotherapy treatment and are far less likely to be neutropenic. We need to consider specific organisms if they've got a line in place, thinking about gram-positive cover, but we also need to think about biofilm-creating organisms, which can, like Stenotrophomonas species, which can make it exceedingly difficult for the person to clear that infection. This is a particular challenge in thalassaemia patients because often, if you're having to have 2 attendances to hospital every 3 weeks for your cross-match and then your transfusion, you can run out of access pretty quickly, or access can become difficult. So quite a few patients do opt for a port. However, if that port then becomes infected, often we'll try and save the port, but unfortunately specific organisms can make that quite a challenge. So, I don't need to tell this audience that splenectomy increases the risk of infection with capsulated organisms, and this does also occur in people living with thalassaemia as well as in sickle cell disorder. Tends to be now usually in our older patient cohort who were splenectomised in a more sort of routine manner to try and reduce their transfusion requirements. So a decent proportion of my patients over the age of 50, 55 have been splenectomised. Or if patients have been diagnosed and treated in other parts of the world, still because of the reduced availability of safe blood, splenectomy is still part of their treatment paradigm. So we try and avoid splenectomy now in the UK compared to how we did things previously. We use penicillin or other prophylaxis. Patient use of this is variable, I'd say. And we also encourage our patients to be appropriately immunised. And so for new arrivals in the UK, we repeat all their childhood immunisations, which includes, Haemophilus, meningitis, etc., and make sure they get their pneumococcal vaccines every 5 years. There's also cardiac factors, so we need to think about impaired ventricular function in this patient cohort. People with historic iron overload and also present iron overload in the heart can have increased risk of arrhythmias, and they can be vulnerable to fluid overload, but also more vulnerable to rapid decompensation if they have cardiac significant infection, because they just have a lesser reserve in that situation. One thing I should have mentioned earlier is people with thalassaemia come to hospital, routinely twice every, 3 weeks or so. To see a thalassaemia patient in the ED or A&E is exceedingly unusual and is literally, hoist the red flag, because it is, it's a surprising never event in our lives. So just as we have flags for our sickle cell patients to make sure they get appropriate and timely care, I do think it's important for the thalassaemia patients to have flags on their record, just so that we're made aware and the emergency teams are aware that this is a person who needs to be taken seriously. Like all of our red cell patients, these are expert patients who've got a good understanding of their condition, and like all our red cell patients, they try and stay out of hospital if at all possible. So it is important to take account of that. So we've also got hepatic factors. So unfortunately, as we know, due to the recent infected blood inquiry, patients who are on regular transfusions have a risk of exposure to bloodborne viruses, and also may have a decreased reserve of their liver due to historic insults, including infections such as hepatitis C and iron, which then can lead to them decompensating in a hepatic way if they develop a overwhelming infection. So the role of iron. Pathogens, so I should have done a declaration of interest at the beginning of this talk. So although I'm a haematologist, I'm actually the child of two bacteriologists. My parents berate me often because haematologists love to prescribe some broad spectrum, high dose antibiotics, which bacteriologists then come along and try and stop us from doing. But it did give me, I don't know, a slightly unusual insight into bacteria, because my dad, still at the age of 80, says that they are distinctly the most superior organisms and will outlive. They were here before us and they'll be here after us. So there we are. I know where I stand. So pathogens love iron, and when we're growing bacteria in the lab, we actually grow a lot of organisms on the agar plates made from blood, or what we used to call chocolate agar, which is made with ly's blood and does look slightly disturbingly like Cadbury's dairy milk in a jar, and that's to give food and nutrients to the bacteria. So we know also that from laboratory work that unbound transferrin, so that's the protein that carries the iron around the body, is actually bacteriostatic in the non-iron overloaded situation. So basically that withholds the iron and acts as a pull whereby it's hanging on to that iron, really tightly bound, and then the bacteria can't get hold of it. We're all a big soup of bacteria, and they're nipping into where they shouldn't be all the time. But because of our complex immune processes, and thanks to transferrin, they don't get the food they need to live, and then Mr. Macrophage or phagocyte can come along and see them off. Unfortunately, iron overload also compromises the ability of phagocytes to kill organisms, and it does that via decreasing the antibody-mediated and also the mitogen-stimulated pathways of the immune system. So iron overload generally is not a positive thing. We also wonder whether there's some direct bone marrow dysfunction due to non-transferrin bound iron as well, because if you imagine if you've got a lot of iron in your liver, you're going to have even more in the bone marrow, and we know that produces free radicals, so you'd expect that might have a directly toxic effect. And it's a different pattern of vulnerability compared, to more central defects in some syndromes, such as chronic granulomatous disease. So the pattern of infections you see in iron overloaded patients is unusual. And these are some of the specific infections that are associated with iron overload. Obviously the ones that we classically think of in our thalassaemia patients like Yersinia, but also more unusual ones like E. coli, mucormycosis, Pseudomonas, and Klebsiella that we might not have at the top of our lists. There's also an impact to the degree of iron overload. So carbapenem-resistant organisms have actually been able to optimize and enhance their iron acquisition pathways. And this is one of the reasons why they've become so aggressive. So you can use iron poor media to grow these things. And there's discussions about whether could this actually increase the vulnerability of iron overloaded patients to these organisms, and certainly it's a bit chicken and egg, because obviously our red cell patients, do spend time in hospital, particularly our thalassaemia patients, because of their regular transfusions. So it's, are they getting, colonised because they're spending a lot of time in a hospital environment, or is it because of their degree of iron overload making them particularly vulnerable to this situation? So chelation can definitely play a role. So desferrioxamine, Desferal is the classic one for this. So it actually binds iron and aluminium, and it's actually derived from Streptomyces pilosus, and that's uses it to scavenge iron from the iron poor environment. And then basically these siderophores that this organism releases forms a complex that then can be absorbed by the bacteria. And they're very widespread, these particular things called siderophores, and they're used by multiple different organisms in different forms. So why has Yersinia been such a problem? It has a relatively low requirement for iron compared to other organisms, and therefore, however, it can utilise other siderophores, such as that produced by Streptomyces, i.e. Desferal, and therefore if we feed it with the desferrioxamine iron complex, then it can have a little party and go a bit wild. Just moving on to the role of iron in transplant-related outcomes, obviously there's been a lot in the news about increased use of transplants and cellular therapies in the red cell setting. And so I think it's important that we think about that when we have conversations with our patients. So we know that raised iron levels in malignant settings are associated with poorer outcomes, and the question is why. So in the malignant setting there's increased fungal infections, but also there's a more general increase in what's called non-relapse related mortality, which does, make you think that is there actually a direct sort of toxicity of iron, or is this all iron-related septic episodes? So there are some areas for future work. Chelators have, particularly XJade, have been used to in mice models to prevent invasive fungal infections. Are we going to reach a stage where all our transplant patients are automatically put on chelation, in which case we're all going to be very busy, or we're going to have to train our malignant colleagues how to prescribe chelators? And also, as I mentioned earlier, I think it would be very interesting to look at the role of non-transferrin bound iron on the bone marrow microenvironment, and does this potentially impact engraftment? Because certainly in my experience, we've had patients who've been transfusion dependent after transplant, but when we've aggressively de-ironed them, they've actually their bone marrow engraftment has significantly improved, and they have become transfusion independent. And I think particularly in the role of red cell disorders and thalassaemia, where transfusion independence is the outcome of these cellular therapies, that's worth looking at. So that's me.
Oh.
Yeah.
Were there any questions in the chats at all?
Yeah.
Okay. Does anyone in the room have any questions? Oh.
Yeah.
Hello. Fungal infections. It's not something we really recognise in the red cell population at all. We always see it back in white cell patients. But after 3 days or 6 days of fever, they'll get HLCTs and So what's, it's definitely recognised. Is there a role for doing more upfront checks for these patients? Also, is there a role for antifungal prophylaxis?
Yeah, so in my experience, my patients who've gone on to develop fungal infections all have something else going on as well. So I can't think of any of our patients who've developed fungal infections outside of broader spectrum immunosuppressant therapy. But if we think about, how, for example, what does more generic immunosuppression mean? Does diabetes count as that, which is very common in our patient, relatively common in our patient populations? Would treatment with something like methotrexate or other sort of more regular systemic immunotherapy for patients who have autoimmune disorders, which we know are higher in have a higher frequency in people living with sickle cell disorder, for example. So I think it's definitely worth thinking of. I think first line would always be bacterial, but then I think it's always worth looking further and not just drawing a line. That I think it's definitely worth keeping on digging until we've at least excluded the significant things that we can do something about. Yeah, so I think it's difficult. So I think the role of prophylactic penicillin or amoxicillin or erythromycin is tricky. Certainly in the paediatric population, there is good evidence for it. In the adult population, yes, there's good evidence for it post-splenectomy. Will immunisation replace prophylaxis? I don't know, because obviously particularly bacteria are coming and they are constantly changing, and so you can only immunise for a certain set, for example, of pneumococcal species. They're not. It doesn't cover every single pneumococcal species known to man at the present stage. Anyway, that may change. We also have to think about. Do we need to think about re-immunising patients? There's some good evidence now that, say, exposure, like this is a viral example, but chickenpox immunity does drop off. And so should we think about re-immunising for other bacterial infections in the splenectomised or poor splenic function population? So yeah, I think it's difficult. I think what the problem is potentially is when patients double their penicillin at home and stay at home. That's a problem. I think that it's a problem when people take their penicillin or other prophylaxis inconsistently and don't take it sort of on the regular. So that causes problems. Potentially, I think I'd either rather people took it consistently or not at all. And I always say to people that if they do have a temperature, that we do want to check them out, because it's in both thalassaemia and sickle cell, it is important that they get treated early, because it can then prevent so many problems further down the line.
Cool. I think that's no more questions. Thank you very much, Emma.
Okay. Okay. So let me.
So we'll maybe just do one or two case studies, if that's okay. Dr. Drasar is sort of standing in for Prof. Porter at the moment.
Yeah. He is. I've got to make some traffic.
Which one is it?
Yeah, you might have unsaved it because I was expecting another one.
Yeah, I mean, I've only put that one on Teams. I'm gonna.
Oh, no, yeah, that's good.
Should I stop the recording, or
No,
you
no,
have
we're
to go
good.
to flow in?
Yeah,
Yeah.
yeah.
So which one? Yeah, you play that.
Right. All right. So here I am masquerading as Prof. Prof. Hilariously was my PhD examiner. So it's we've got a long history together, and hopefully I'll do a not too terrible job. So the first case is an 8-year-old patient with beta thalassaemia intermedia. So like many of these patients was splenectomized in childhood and is non-transfusion dependent, has never used Drasar and has a very good, well, pretty good, I would say, ferritin of 200 to 300. So, you know, we're all thinking, not much going on here. However, in August, they had a sudden onset of abdominal pain, again, not that unusual in 8-year-olds, from my experience with my daughter, but also significant fever, and was given had a stool culture, Yersinia was grown, and was given, I think that's amoxicillin, and they felt a lot better. Unfortunately, a month later, they had further episode of abdominal pain. This time, there was no Yersinia in the stool initially, and they actually had a potential diagnosis of cholecystitis, which again is very commonly seen in our red cell patients. However, on a repeated stool sample, Yersinia was grown again. So they actually went on and had a cholecystectomy in October, and the histology of that showed some chronic inflammatory changes. So that's a case of, you know, that our patients can have multiple different reasons for high fevers and abdominal pain. We always think of Yersinia. I think I've seen 2 cases in 20 years in red cell hematology, but when it does happen, it's very significant. I have, however, probably seen, I don't know how many cases of cholecystitis in my patient population, but 8 years old is significantly young for that presentation. So it is definitely an unusual presentation from that perspective. So then we have the second case. MG, who's a 19-year-old lady with transfusion-dependent thalassaemia, who had a 24-hour history of significant fevers over 40 degrees C. Also some rigors, diarrhea, nausea, vomiting, a vague abdominal pain, and slightly unsurprisingly with that fever, a frontal headache. However, significantly tachycardic with a pulse of 130 and possibly reduced air entry at the left base. No abdominal mass or tenderness on examination. So this girl had been transfusion dependent since her first year. Ferritin pretty well controlled, 1,000 to 2,000, not too bad. On DES, 2.5 grams 5 times a week. And was splenectomized as a child. She had a previous history of unexplained septic episodes and was on penicillin prophylaxis. So she was given paracetamol and erythromycin for 24 hours, but was diagnosed, somewhat surprisingly, with a viral illness. Things proceeded. She was then treated over the weekend for sinusitis with amoxicillin, but her fever was no better, still 39 to 40, and her diarrhea was actually worsening. So at this stage, ciprofloxacin was added. I assume this is a historic case because normally you have to like sell a kidney to bacterial gene micro now to get Cipro, and her Drasar was held. So the next day things looked like they were getting better, certainly from a diarrhea perspective, but unfortunately her fever continued. So blood cultures had hatched partially, and gram-negative rods were seen. So she was switched to amikacin and azolacin, and an ultrasound abdomen was performed to try and narrow down the differential, and that showed mesenteric adenitis. Diarrhea was settling, temperatures coming down, and then final cultures came through from the blood, which showed Yersinia. Stool cultures were negative for Yersinia, but an E. coli was also isolated from her urine, and so she was discharged on Septrin. Now, the next year, she continued to have diarrhea at the end of each of her 5 days of Desferal. So she ran hers together, didn't space them out. Naughty. So she was having slight abdominal cramps, and at this stage, particularly because of her previous history, stool cultures were sent and Yersinia was isolated. She did have positive Yersinia antibody titers, and basically then was started on a significantly prolonged course of Septrin, 2 tablets twice a day for a month, and things seemed to settle down again. Unfortunately then the same story reoccurred. Again, antibody titers and stool cultures were positive, and the Septrin was then continued for 2 months. So this poor woman had a lot of Septrin. So normally it can be localized, which is benign and self-limiting, presenting with like ileitis, gastroenteritis, but sometimes peritonitis, or it can be more generalized, and that can be fatal with classic sort of sepsis appearances, but also an associated polyarthritis, erythema nodosum, or more rarely hepatitis as well. What can predispose you? So eating raw pork, hepatic, so cirrhosis is a predisposing factor. Underlying malignancy, because that enables the bacteria from the gut to nip over into the bloodstream. Diabetes, chronic immunosuppression, and as I said, commoner in iron-loaded patients and those who've had iron overdose. And because of Desferal being a siderophore that Yersinia can use, Desferal use is a predisposing factor. And this is quite commonly seen. The other population this commonly affects are the dialysis patients as well. So think about it in perhaps our, I tend to have more sickle cell patients than thalassaemia patients who are on renal dialysis. So worth keeping in mind for that particular patient group too. Okay, I've done that already. How much time do we have? One more?
Yeah, one more then.
Okay.
Question.
So we've got case 3, a 51-year-old person born in Hackney of Cypriot extraction, and was aged, so was born in 1963, was aged 18 months, was diagnosed with thalassaemia major, transfusion-dependent thalassaemia, and had a haemoglobin, because we used old money then, 5.5 or 55, as we would say now, with a very high fetal haemoglobin. Was transfused monthly and was an IVS-1 110 homozygote. So was splenectomized, as was commonly done then in 1975, age 13, and in 1978 had a PUO, diarrhea, and Yersinia enterocolytica isolated. So Desferal was started age 17. So you can imagine that, you know, they've had 16 years, 16 years of transfusions. So this patient has got significant iron overload. Desferal was started. I do have just as a side note, I do have a proportion of my older patients, and Prof definitely has the same, who were pre-transfusion, pre-chelation era thalassemics. So, we went through a stage where we didn't transfuse patients and they died of anemia, then we transfused them and they died of iron overload, and then we didn't really know what the optimum regimes were for using chelation therapy. So some of my patients had like high dose IM, Desferal, that used to be given to them at school. Some of them had the big clunky pumps that you had to like wind up. So, it was all an evolving situation, let's put it that way. So this patient had presenting a ferritin at that stage of over 16,000, which is pretty high. So aged 21, they had a bone age of 13.5 and were the 3rd centile for height. Probably not surprising given their ferritin of 16,000. I'm sure they were significantly hypogonadal. And yes, this was diagnosed later on in the 80s. So they found taking Desferal subcut challenging, which isn't surprising, and ran a ferritin of 5 to 10,000. And as I say, this chap was found to be hypogonadal and was commenced on Sustanon. Did have occasional hospital admissions for their iron overload, and on these occasions were given IV Desferal 5 grams a day for a week to try and get on top, kickstart the de-ironing process. Unfortunately, later on that year, had actually developed heart failure due to iron overload and was commenced on IV Desferal via a pump, via a portacath, and full recovery was achieved. So now roll on time-wise. So the patient's now 51. They've got cardiac arrhythmias and are warfarinized and on metoprolol. They've got widespread endocrinopathies, so they're hypogonadal, had hypoparathyroidism and also insulin-dependent diabetes. And they've also had back pain since 1991 due to significant osteoporosis, although that in combination with permidronate and hormone replacement has led to a significant improvement in bone density. So the main problem that this chap had from an infection perspective was recurrent Klebsiella infections. So they developed a chest wall abscess, which was found to have large amounts of Klebsiella when it was cultured and was treated surgically with antibiotics. They then had a wound on their cheek filled with pus. Again, Klebsiella was isolated. And they had a chronic cough and was found to be heavily colonized with Klebsiella in the sputum. And again, further antibiotics were given on 3 occasions that year. In March of 2013, they developed a pharyngeal abscess. Significant fluid filled from the clivis to the pharynx. This is almost like a old-style quinsy or diphtheroid issue, and actually led to compromise of the airway, so they had to be intubated and ventilated, urgent incision and drainage of the collection, and you've guessed it, the fluid cultured grew Klebsiella. Again, this chap, no growth from a foot swelling and ulceration. However, later on, the infection progressed and our old friend Klebsiella had reoccurred. So you can see that's like a nasty looking foot there, and you can see how Klebsiella is particularly particularly persistent in soft tissues, and I think soft tissue infections, to try and get a decent amount of penetration into the surrounding tissues around the wound can be a challenge. So he was admitted under the vascular surgeons they IMD'd and used VAC dressings to try and improve that ulcer. So you can see here they did a big old drainage. The wound started to heal. He was still cultured. He was still culture positive with Klebsiella everywhere on long-term trimethoprim. So you can see they actually had a good result from that wound. Unfortunately, he then developed urinary symptoms, and Klebsiella was there again. And so I think that's the moral of this story is that once a patient becomes colonised with Klebsiella, it is exceedingly persistent and hard to get rid of. And the problem is it's a highly effective organism, and it sort of pops up all over, it pops up all over the place. So it's not one of these things, it's not like a staph where you can get it, it tends to be just skin infections and post-influenza pneumonia. It really can, if there's a space in your body, it will sit there quite happily, causing problems. And the other issue with Klebsiella is the potential for resistance as well. So it's always very important that you get full sensitivities for these patients. That's it.
Thank you very much. Does anyone have any questions before we break up for lunch?
Yeah.
Does gut health and nutrition help?
Oh yeah, does gut health and nutrition help? So there's a lot, as we know, around about the microbiome now. And I think definitely, eating, we know that, say, for example, with C. diff, Clostridium difficile, that becomes a problem when we treat with antibiotics and we wipe out the patient's normal bacterial flora in their gut. So, definitely I think that maintaining like a good, broad, healthy diet is only going to improve things, because then you won't develop a overgrowth of a particular bacteriological, substream. Yeah.
Just got one question online at the moment. What is the correlation between iron level in the blood and bone age? What is there?
Oh yeah. So that's basically if you've got too much. So that basically shows that their calcification has been inadequate, and that happens when patients are iron overloaded. They can become iron overloaded anywhere, including the pituitary. They don't produce any sex hormones, so they don't go through puberty normally, and that's the peak time of mineralization for the bone. And so then they end up with a low for age bone age, and so higher the ferritin, the more likely patients are to be significantly iron overloaded in all compartments: liver, heart, pituitary, elsewhere.
Thank you.
Any other last questions before we break up? No, it all sounds good. Thank you very much. Is there another one? Okay, so what time are we back from lunch?
45 minutes. So 1:15. Should we restart it?
And guys, there will be a lot of food, so you have more than one helping.
Yeah. Eat big, guys.
Well done.